Hello everyone, welcome to Urology Podcast with Mr. Danasekram. My name is Mr. Abimbola and I'll be discussing trust-guided prostate biopsy from the good to the bad. Where do we stand now? I would like to say foremost that Mr. Danasekram has been a pioneer in transitioning from trust to TP biopsy, and he is currently BPH lead in West Midland with a lot of interest in medical education and training. He is a very good person you can always approach if you find yourself in West Midland and should you need to learn TP biopsy and all the minimally invasive prostate procedures. As you know, prostate biopsy is one of the most commonly performed urological procedure for histologic cancer diagnosis of suspected prostate cancer. The traditional indication is based on a number of things, including the PSA level, an abnormal DRE, and a PSA density as defined in the latest guidance by PSA density more than 0.15. MRI, on the other hand, brought a new dimension in the recommendation for prostate biopsy. It is reported as Pirate score of 1 to 5, and the higher the score, the more likelihood patient has got clinically significant prostate cancer. And by this I mean a histologic Gleason score that is more than 7. For a very long time, trust biopsy with fusion offers good sampling methods for prostate cancer diagnosis. However, post-biopsy sepsis remains a challenge, and on the other hand, TP biopsy offers a way out of this significant complication. Let's review some literature and let's come to a conclusion. And whilst we go through that, I want you to think, what do you do in your trust, and what are the current evidence as to what you do in your trust. This is quite an interesting picture of a patient being drawn into underward as a result of sepsis leading to multi-organ dysfunction. The mortality rate of sepsis remains high, and each hand you are seeing in the picture is a trust needle biopsy with potential to introduce bacteria into the system and onward leading to sepsis. Trust leads to a breakdown of body natural defense mechanism and in turn predisposes patient to sepsis. The reality of trust is that in the region where trust biopsy remains the main route of prostate sampling, infection has been rising over the years, and also antimicrobial resistant organisms. And this is from a data from CR Medicare, and they also found that 30 days hospitalization rate was 6.9% as compared to 2.7%, and this dates back to 2011. And multi-drug resistant infection also continue to rise. In the UK, a prospective multinational multi-center prostate biopsy study, an outcome of global prevalence study of infection in urology, found a significant hospitalization following sepsis. Out of 702 men that were recruited for the study, 521 had their data analyzed, and they noted febrile UTI in about 3.5% following prostate biopsy, and as well as 3.1% was hospitalized. Now, what struck me most in this study, and in fact the interesting part, is that 98.2% had prophylactic antibiotics, and in the subgroup analysis, all patients who were hospitalized had a pre-procedure antibiotics. Now, this becomes important when we consider what antimicrobial therapy we give for patients prophylactically when they come for trust biopsy. In my trust, we used to administer ciprofloxacin, metronidazole, as well as gentamicin, and as you can see, the hospitalization rate as well as the febrile UTI rate underscores the burden of antimicrobial resistance, and by extension something we need to reflect on when performing a trust biopsy. High-level evidence from systematic review of complication of prostate biopsy also found incredibly low rate of infection in transperineal biopsy and a significantly high infection complication in trust, with 10 to 30% having resistance to fluoroquinolone. In another multi-center Australian study, the rate of readmission following TP biopsy was 0, and the rate of sepsis following trust remains challenging in their study population. Trust, although it is cheap and convenient to start with, but in hospitalization is high. So the question remains, are we saving money or losing money? So let's turn to the cost analysis. This is a study in the US on cost analysis of managing post-biopsy sepsis. And in their study, patients who had post-biopsy sepsis had about 1.1 to 14 days length of hospitalization, and an ICU admission rate was 1.1 to 25%. And indeed, it cost huge amount of money to manage a patient with sepsis following TRUST. Let's do some math. Assuming an average you spend is $12,000 to manage post-biopsy sepsis, and you have 4 patients in a year requiring this level of service, this would amount to $48,000 in a year. And imagine the multiplicity of this amount if you were to take sub-region in UK into consideration. We are talking about a huge amount of money that can potentially go into some other care. This is quite an interesting slide and story for me. On the left hand corner, we saw one of the reasons why we voted Brexit. Let's fund our NHS instead of sending £350 million to the EU. And when you go further downward, you would see Brexit going in one direction and the European Union on the other direction. And in January 2020, we voted for Brexit, and Brexit came into existence. And on the right lower corner, you will see Sandwell General Hospital, which achieved TREXIT in 2022. Now, what is TREXIT? TREXIT is exit of trust guided ultrasound biopsy of prostate. And now, so what strikes me most is the fact that a Southeast Cancer Alliance in London was able to achieve TREXIT before Brexit, and they did achieve their TREXIT in 2019. Like I said, SWBH achieved TREXIT in 2022, and just over 2 years after Brexit, and thanks to the clinical lead as well as Mr. Dana Sekran in seeing to the end of trust biopsy within the trust. But there are a good number of trust in the process of transitioning. Let's talk about TREXIT. In this prospectively randomized study of 1,501 patients who were randomized into 3 groups of A, B, and C, with group A being trust plus empirical prophylaxis, and group B was trust plus targeted antimicrobial, and group C was freehand transperineal biopsy plus empirical antibiotics. Now, what they found that it was targeted antimicrobial for trust did not reduce overall risk of sepsis, and patients who had freehand transperineal biopsy had a lower risk of sepsis of 0.4% compared to 2.2% in the group with trust. In the era of antimicrobial stewardship, we should be looking into promoting practices that reduces the burden of antimicrobial resistance, improves patient outcome, and also reduce the cost of managing complication of a procedure. Can we achieve this through TP biopsy? A systematic review and meta-analysis of infection rate following non-biotic transperineal biopsy versus biotic transperineal biopsy showed no mortality in both arms and significantly reduced risk of sepsis in the non-biotic group. And this is quite interesting because we can achieve a transperineal biopsy without use of antimicrobial. As we bring this talk into conclusion, what does EUA recommend? TP biopsy is the first choice for prostate sampling, and trust biopsy should be offered as the second choice. Hence, each hospital should then need to strive to comply to this guidance for effective and optimal care. I will leave you with this. In a subway game system, the avatar aims to collect coin without being hit by a moving train. How many coin will he collect before being hit by the train? Because once he's been hit by the train, he can no longer acquire any coin again. The train is the infection, and the coin is the trust needle, and every needle you drive into the patient risks them from being hit by overwhelming sepsis. Whilst over the years, trust has remained a good choice of route of prostate sampling for cancer diagnosis of prostate cancer, if you look at the risk pertaining to these, we may be looking at a bad choice, especially if TP route is available. I therefore say to all that TP remains the first choice, of prostate sampling for prostate cancer diagnosis, and we should all get started with this. Thank you all.